Was the question is which does not cause diarrhea or what hypercalcemia will cause? Which does not cause diarrhea, right? So, which does not cause diarrhea was the option? Okay. Diabetes was there in the options? Okay, diabetes causes constipation. Is there any diabetic diarrhea also? Due to any autonomic instability. But hypercalcemia was there in the options, correct? So, yes, that's right. That's the reason hypercalcemia is the one which does not cause diarrhea, is what we can conclude. Then coagulation failure is not a feature with a cardiac defect, but definitely with eclampsia and also abruptio placentae and amniotic fluid embolism. Riddle-Walker coefficient is the one which is used in order to compare one disinfectant efficiency with that of the other. Oral hairy leukoplakia is caused by the Epstein-Barr virus, as all of you know very well. Then what are all the important functions and roles of the acetazolamide? Acetazolamide is a carbonic anhydrase inhibitor. It is used for the epileptic seizures. Now the quiz question. Which type of epileptic seizures? Very good. Absent seizures, benign intracranial hypertension, altitude sickness, cystinuria, ductal ectasia also we use it. They are the different reasons why we basically use it. Now, for the discordant growth between the twins, what is generally responsible? It is the twin-twin transfusion syndrome which is responsible for the discordant growth, which is more common if there is a monochorionic, monozygotic twins. And when do you call discordant? If the size discrepancy is more than 20% between the two twins, you like to consider it. And what are the most common vascular anastomosis that you have? For the juniors, next year question. Artery to vein anastomosis is the most common type that you typically have. Cholelithiasis can be caused by the hemolytic anemia because of the pigment stones. It can be seen in pregnancy because of the high levels of stasis and obesity. And a low protein diet is basically lithogenic, not the high protein diet is what need to be remembered. Now, which porphyria is transmitted autosomal recessive and dominant? You must be very sure, doctor, different porphyrias, which enzymes are involved is a favorite topic of the examiner. Now you have 5 porphyrias which are called autosomal dominantly inherited. Acute intermittent porphyria, most of the cases of erythropoietic porphyria, and hereditary coproporphyria and variegate porphyria. Now if you take the porphyria cutanea tabda, there is a small exception about it. Though it is autosomally dominantly transmitted, it also has a sporadic occurrence also. Then which are autosomal recessive? You have the congenital erythropoietic porphyria and rare cases of erythropoietic protoporphyria and LRD deficiency porphyria, they all are the ones which are implicated. So what is your answer in this case, doctor? Congenital erythropoietic porphyria is the one which is basically autosomal recessive out of the options which are being given. Now it is the strawberry hemangioma which will have a rapid growth and slowly it will regress as the child grows bigger. Whereas the port wine stain, a stain can never be removed. So stain remains without losing. Now axillary node status is considered being the major prognostic factor in breast carcinoma. I am quite sure you must have felt the paper very cakewalk except few surprises. These are all standard questions. Now which is not an amino steroid derivative out of them? Alkyronium is a curare alkaloid family which is peripherally acting muscle relaxant is what need to be remembered. Follicular pink scaly rash of chronic type. Many times we discuss this in our dermatology, regular dermatology sessions. Pityriasis rubra pilaris is a chronic papillosquamous reddish orange scaly plots which have a palmoplantar keratodermic lesions is a very characteristic feature. This reddish orange plaques on the trunk which you see in the case of the pityriasis rubra pilaris, and there is the follicular hyperkeratosis seen on the dorsal aspect of the proximal phalanges, and the plantar keratoderma with the orange hue on the soles is what you typically come across in rubra pilaris, and this is the palmar keratoderma with orange hue on the palms. Virtually it will be like that holy, we apply that this thing, like that if you see one patient's hand you will remember. Now which is that chronic winter rash in the elderly people, it is called as. It is also called the eczema crequille, otherwise steatotic dermatitis, which is pruritic. Dry scaly polygonally fissured skin with irregular scaling is what you have. It is more or less like a cracked porcelain like appearance is there. Lower extremities, elderly people who are aging, who are dried out in the winter season is a classical presentation, is what need to be remembered. This is how the steatotic dermatitis on the lower extremity in an elderly man typically looks like on the lower extremity. Steatotic eczema winter season is what you have to remember. Hypopigmented patch, erythrodermic patch and plaque, they are all the features which you see in the case of the leprosy. Now this is an interesting question. Options are too long, difficult to recall, but let us debate on each of them. There are no bronchial markings with only lucency. That is how the pleura filled with air with a compressed lung looks like if there is a pneumothorax. Then there is a shift of the lung towards the hilum, definitely, just like a balloon which has contracted, it goes towards the hilum. And it presents like a opaque lesion, that lung which is contracted. All of the three are true, but fourth, what is the correct, is it the same wording? Is there any ventilation of that lung? That lung cannot expand actually. So that is how you call tension pneumothorax or not a tension pneumothorax, all depending on the size. So I am not sure what was there in the examiner's mind in framing this. Yes? Markedly increased, very much. If you see, it is almost like the bone. The lung which is contracted, compressed by the air, will typically look like a hilar mass, almost. I remember people diagnosing, reporting it as a enlarged hilar. So our radiology professor said it is not enlarged hilar lesion, it is a compressed lung due to the pneumothorax. Patient is in dyspnea. Why are we talking about enlarged hilum? So it is very opaque, just like the heart shadow. Okay. Now, which is not true about MRI? MRI is better for the soft tissues. CT is better for the bony lesions, calcified lesions is what need to be remembered. Now this is a good question. How many answered this correctly, doctor, in the exam? Other than D, what were the options? Let us debate from there. What was the answer? Effective half-life was the answer? Excretion was given, good. That is what I was also expecting. Metabolism, excretion, breakdown, everything is interchangeable. Let us talk about what is the different half-lives a radioactive element can have. It can have one thing which is called the physical or a radioactive half-life, which is the time required if you put it in the nature, not in the body, for it to become half. Biological half-life is the amount of the radioactive substance which is excreted, exhaled out, perspired out, and the body gets rid of it. Whereas effective half-life is the combined, both its physical half-life and the body's half-life. Combined together is basically called the effective half-life. So effective half-life is biological half-life into radioactive half-life is what need to be remembered. Now let us talk about the electroconvulsive therapy. Is it accept question or straight away? Okay. We use anesthetics very much. We also use pulse oximeter. Was it there? Oximeter? Okay. Pulse wave? Pulse wave therapy. Okay, then anyway D is dead then. So C is definitely given. Okay, now the question comes to you. What is the anesthetic of choice which you like to give in electroconvulsive therapy? Yes, any choice? But before that, what is the protocol? Begin oxygenation, administer anesthetic, muscle relaxant, and then there are two ways. You can do it unilateral or bilateral. Electrodes can be placed, and we often use methotrexate is the most commonly used anesthetic in the management of the electroconvulsive therapy patient is what need to be remembered. In obstructive sleep apnea, morning time somnolence can be there, and there can be respiratory insufficiency, will there be nocturia? I don't have reference on B and C. Impotence, definitely it is not cited as one of the common causes. In fact, patient is awake the whole night. C and B I am not very sure which is the possible answer. You can give me a better judgment. I mean, I have seen a lot of cases of obstructive sleep apnea managed on the ventilators, but when it comes to entrance, management is different from what small things they will ask. Will there be males or females more? But clinically you will see both males and females. You don't know what to answer in the entrance. So I have not seen patients complaining nocturia because they have obstructive sleep apnea. At most they can't, because they are obese, they can't get up. So on the bed they can pass the urine. That is a possibility, rarer possibility. Now, which is contraindicated in pregnancy and lactation? How many want to immediately raise a voice on the parliament floor if I say metronidazole? What was the other option? Okay, then it's fine. But metronidazole as such is called as a C-class drug when it comes to pregnancy. Some reports say don't give it in lactation, some say give it. So that is the reason metronidazole is a still controversial position. So that's what I was looking at. Now, which drug causes gynecomastia? It is a ketoconazole which can cause gynecomastia in the case of the males. Cholesteatoma, where does it arise, doctor? Prussic space, where is it located? Nasopharyngeal carcinoma, where does it arise? Similarly, some fossa is there, no? Rosenmüller's fossa. Okay, well, who is this Prussic? Where is he located? But before that, another quiz question for the next year students. Which is the most common site for the fistula formation in cholesteatoma? It is the lateral semicircular canal. Now, epitympanic cholesteatoma start in the Prussic space, which is there between the pars flaccida and the neck of the malleus, with the upper boundary of the lateral malleolar fold, and from there they will spread. From there it will be spreading to posterior epitympanum, posterior mesotympanum, and anterior epitympanum in that order is what need to be remembered. Natal teeth, immediately as a newborn is born, teeth are there, which are called natal teeth. They are more common in the upper jaw or the lower jaw, maxillary or mandibular. Mandibular incisors are generally the natal teeth. They are very loose. What is the problem if you leave it? The baby can aspirate it. So remove it is considered to be the rule. There. Yes, doctor? Very always? Yeah. If that is the reason they are called natal. No, in those babies who have the natal teeth, they are there when they are born. Otherwise all of us had teeth after birth. Is it not? I mean, postnatal, we all had teeth. We were not all born like Mahishasura or any other Rakshasa, right? With I mean English, okay. We'll also give for the next year batch students English coaching. How to read the question properly in the exam. Alright, they are the part of the lower central incisors. Now, which part of the brain is most often contused in the case of the head injury? Actually, it is the orbital surface of the frontal lobe is most commonly injured, and the temporal lobes are the second most common injured. That is to the reference. But you have any reference about parietal? Hope not.